Renal failure. All right, renal failure is going to come back to bite you in the butt with many patients. So we're going to take a little bit of time with this one. And like I said, you're going to be seeing renal failure a lot. The poor kidneys, they're not part of the ABCs, and they get damaged a lot. So poor little guys. We're going to talk about two kinds of kidney failure. The first kind being the acute kidney injury, and the second being chronic kidney disease. One happens abruptly over hours to days, usually from an acute or treatable cause, and the other one, like I said, is long-term, develops over decades rather than hours to days. The reason we have so much acute kidney injury is because the kidney is very easily damaged. It's very sensitive. It's a sensitive little guy, and it doesn't get the attention it deserves. It really does do a lot for us, but we don't end up treating it very well because it's not a quote-unquote vital function. We do a lot of stuff to save our heart, our lungs, and our brain, but unfortunately the kidney gets bypassed a lot of times. So let's talk about this delicate little sweetie, and let's talk about what happens when we get an acute kidney injury. So these delicate little sensitive kids, we've already talked about these kidneys. They like a certain pressure, they like a certain flow, and they like a certain oxygenation. I mean, it's only their right. They're a very hardworking organ. And unfortunately, there are three main reasons that we have kidney failure. We go through 4 stages. Actually, there's really 2 stages, and then you get to go in a path. You go through the first stage, and there are 3 main causes of kidney injury, and that's the pre-renal, the intrarenal, and the post-renal. Those are causes. And this is the first stage is when you're having one of these problems, and the kidney is being damaged, but it's kind of under the radar. Our job in this first stage is to get rid of the cause of kidney injury, and then there's no problem. Unfortunately, because of, we'll show you what these causes are, the pre-renal, the intrarenal, the post-renal, sometimes we can't fix the cause of the problem right away, and unfortunately, if we're unable to treat or it's not detected, we move on to the second stage. Second stage of kidney failure is the oliguric, or the decreased urine output stage. So when we talk about kidney failure, and I said you're at risk for kidney failure, I'm usually talking about the symptomatic kidney failure, which is oliguric, meaning decreased urine output or not as adequate urine output. Hopefully we treat it in the second stage and we're able to recover our sweet little delicate friends, and we get either healing, or if we're unable to treat it or it's too long before treatment in that second stage, you can end up losing. So we kind of have like a little branchway here. We have 2 opportunities to intervene to save our kidneys. If we miss both of those chances, we end up going down the bad path. If we miss all of our chances and we can't get these kidneys, we can end up with either loss of kidney or end-stage renal failure, depending on how much of the kidneys were damaged. Hopefully, we can get these causes fixed, we can support the kidney, and we end up healing. So the third stage and the fourth stage is basically meaning you went through the second stage, we fixed everything, and now you are healing and you're going to get better. That second stage, though, we do have a chance of being able to lose that kidney as well. So our goal is to keep acute kidney injury. We're going to maintain that kidney, get it what it needs, and get it to healing. So let's talk first of all about what causes it. This is kind of important, will probably be a test question, are the different causes of acute renal failure. Pre-renal means something happening before the kidney, which is basically you're not perfusing your kidney. Something is happening, and it is most likely low blood pressure that is causing decreased perfusion to your kidney. So pre-renal is inadequate perfusion of blood to the kidney. So of course, anytime you have a low blood pressure or you're super dehydrated, or your heart just can't pump to the kidney, anytime you have decreased blood flow to the kidney, you are risking, and you are in the first stage of kidney failure. You have to fix the problem. Now, easier said than done. Dehydration, we can hydrate them. Hypotension, we can give them fluids. Extensive blood loss, where you place the blood. Decreased cardiac output. Heart failure, we try to fix the heart failure. We do our best, but sometimes if we can't get the blood pressure up or we can't fix these causes, we will move into second stage. So any of decreased perfusion to the flow is considered a pre-renal cause of acute kidney injury. Direct injury or necrosis of the renal structures is called intrarenal. That's direct damage to the kidney. So anything from a nephrotoxic med that actually physically damages the kidney, acidosis, when our body is acidic for a long time, cells lyse and die. That includes kidney cells. Severe hypertension damages the glomerulus, damages our filter. The long-term damage of hypertension, it causes chronic, but severe acute hypertension can cause direct damage to the kidney. Infections cause direct damage to the kidney. And then clots going in and causing actual damage to the kidney as well. So things that are thrombolytic, that's where we have blood cells that will go in and actually get stuck in the kidney tubules, in the bloodstream around the kidney tubules, causing the kidney to actually get damaged. So damage to the actual kidney, so when we talked about in urinary problems, the glomerulonephritis, the pyelonephritis, those are intrarenal causes. And when we say you're at risk for renal failure, they're actually at risk for intrarenal failure or direct injury to the kidney. And that's caused by backed up fluid, actual bacterial eating infection, anything that's damaging the kidney itself. Pre-renal is inadequate blood flow. Intrarenal is a direct damage to the actual kidney structure. And post-renal, we were talking about in our urinary problems, is an obstruction to the outflow of urine. So whenever we are not being able to fully empty that renal pelvis, fluid will back up into the kidney, causing renal failure. But if the cause is obstruction below the kidney, then it's called post-renal. So think about obstructions as post-renal. Intrarenal is damage to the kidney, and pre-renal is inadequate blood flow. So anything that causes an obstruction is going to be obstructive post-renal causes. So you can see that we have numerous things that can cause damage to the kidney. They're delicate little buddies. They need adequate pressure. They need to not be damaged, and they need to not be obstructed. So if we have an obstruction, you're at risk for post-renal failure. If you're giving them a nephrotoxic drug or they have an infection, you're at risk for intrarenal failure. If you have low blood pressure or dehydration or decreased perfusion from the heart, you have pre-renal. Again, they're just words. They're all risks for renal failure. If we do not fix, so if for some reason in our obstructive we got a renal stone in the ureter and we don't get that fixed, then your patient will go into stage 2. So when we were talking about you need to get that obstruction fixed with your renal, your output is decreasing, you've already bypassed stage 1. As soon as you see decreasing urine output, you're into stage 2. So sometimes we never even know that we are in stage 1. There's no signs and symptoms of stage 1. None. 0. Zip. You just have a cause that you need to get fixed. So that is the hardest thing to remember. Stage 1, it's your problem that is causing your risk. That's why it's called the risk or onset stage. So if we can recognize and treat here, we never move on to the stage 2. So this is really problem treatment going on here. This is where we're going to mention your nephrotoxic meds. That's not a giant list, but that's a very, very important list. Things that are damaging to the kidney itself, things that are toxic to the kidney. Many antibiotics. You will always see with antibiotics that they cause damage to the kidney. You need to follow their BUN and creatinine because it is a risk. These antibiotics go in there and they help the immune system. They're great at fighting infection, but they are terribly toxic to the kidney themselves. So whenever you are on an antibiotic, you are in an intrarenal risk for failure. You've got to make sure that that patient stays hydrated while they're getting antibiotics because that is toxic. Chemotherapy agents, very toxic to the kidney. Contrast media, and when we talk about radio contrast media, we're not talking about anything over the radio. We're talking about CT scan dye is what radio contrast media really is. I'm going to just write that there so that you don't know. This is contrast dye, and this is thick radioactive basically dye that they put in so they can see things on the CT scan, but it is terribly toxic to the kidney. Turns out proton pump inhibitors, which are we'll learn about those next unit when we talk about GI, antacids, are actually directly toxic to the kidney as well. So those four classes, antibiotics, chemotherapy, contrast dye, and proton pump inhibitors, if your patient is getting a nephrotoxic med, you need to keep it as a low dose as possible or flush it. Anything that we're giving that's toxic, if you get a toxin on your skin, you're going to flush it. If we're putting a toxin in your body that's going to hurt our kidney, we want to flush and make sure it's very diluted by the time it hits the kidney. Any medications that reduce blood flow to the kidney, these are not directly nephrotoxic. They don't hurt the kidney themselves, but they reduce blood flow, giving you a pre-renal cause of acute renal failure. So diuretics, nonsteroidals, and antihypertensive medicines, you're like, wait a minute. These are treatments. They're important. Yes, they are, but they reduce blood flow to the kidney. And so anytime we reduce blood flow to the kidney, we are putting ourselves at risk of kidney failure. So when you are on nonsteroidals, antihypertensives that are dropping your blood pressure very fast, not antihypertensives controlling your blood pressure, but maybe too high of doses of antihypertensives, maybe very strong fluctuating doses of antihypertensives, or antihypertensives that drop your blood pressure below, 90 or so, or dropping your blood pressure too fast. A kidney that's used to a blood pressure of 180 and now all of a sudden has a blood pressure of 100, that's a reduced blood flow to that kidney. And diuretics decrease fluid volume, which can decrease blood flow. So I don't have those in bold, but they are used with caution because they reduce blood flow to the kidney, which is a cause of acute renal failure. So again, when we are at a risk of renal failure, we are trying to remove the cause, but the big thing that we are watching is our urine output. Anytime your patient has decreased perfusion, a toxic reason like an infection or a nephrotoxic med, or they have an obstruction, we need to be watching urine output. We're watching that kidney, and we are hoping that we stay in and we eliminate the underlying factors so we don't go into the second stage of kidney disease. But we do need to watch right now for the second stage of renal failure. Your BUN and creatinine levels on your lab work are important as well, but again, we will see the decreased urine output. You will watch your BUN and creatinine levels, especially if you are in any of those conditions. I want you to look at your BUN and creatinine and just double check that everything is okay. High levels of normal are okay, but it shouldn't start going abnormal. We want to watch this, and you might not be able to get to that underlying cause right away, but if you know you're at risk for renal failure, you're going to start watching your BUN and creatinine. Electrolytes, they shouldn't be changed at this stage. You're just at risk. Nothing should be changing. There's no signs and symptoms. Keep an eye on your urine output. because the second stage, like I said, and we're still, really the first stage, there is nothing to do except monitor and eliminate the underlying condition. If pre-renal is decreased perfusion to the kidney, get perfusion to the kidney back. Get IV fluids on the patient, get the heart pumping better, get that pre-renal condition fixed. Intrarenal, get rid of the toxic conditions and flush, flush, flush. If you have an infection, get the antibiotics on, which are nephrotoxic. So remember, when you are treating a kidney infection, it is flush, flush, flush. Get those toxins out of the kidney. And post-renal, you've got an obstruction, remove it or bypass it. So if you have urinary retention, or you have a physical obstruction like a prostate or a urinary stone, you have to remove it or you will move on to stage 2. So 3 different causes of stage 1. The treatment of stage 1 is get rid of those causes. Avoid any dehydration, flush, flush, flush. Get rid of any. Ask the provider if they are at any risk of anything. Make sure they know that what meds could damage the kidney, and avoid them. And we're looking for any further damage to the kidney. Really, the patient's not going to see this stage. This is for you to know what the risk factors for renal failure are, and the first stage is knowing and treating the risk factors. The risk factors are pre-renal, decreased perfusion, intrarenal, nephrotoxic or infections, and post-renal are obstructions or urinary retention. So that is the first stage. Hopefully we will be able to intervene. The second stage is where we start having decreased urine output. This has a definition. Now, we were saying adequate urine output is less than 0.5 milliliters per kilogram per hour. That is true. I'm going to put both of them on here, actually. Let me add that to this list, and you can add this to your urine production of less than 0.5 milliliters per kilogram per hour, or 400 milliliters in 24 hours. Either one will count for oliguria. If I am, let's pretend in a beautiful world that I'm, 80 kilos, okay? My adequate urine output is 40 milliliters per kilogram per hour. If I start putting out less than 40 milliliters per kilogram per hour, and I'm putting out 30 milliliters per hour, I'm putting out how many per day? Hang on one second. Had to pull up my calculator there. If I'm putting out 30 milliliters an hour, which is less than what's appropriate for me, I'm still putting out 720 milliliters a day. So there is kind of a range in oliguria there. The defined definition by the American Kidney Association is less than 400 milliliters in 24 hours. But I want you to suspect oliguria when you start getting less than your adequate urine production. Okay? I'm still putting out 700 a day. You might continue to monitor that, and if it drops down, and you start monitoring it hourly. Now, really, when we're looking at these patients that have a risk for renal failure, we should be checking their urine output more than daily. We should be starting to look at them hourly at this point. Any patient that is at risk for renal failure, please start monitoring their intake and output every 4 to 8 hours rather than waiting for a 24-hour total. We will be very much behind the 8 ball if you wait 24 hours to find out what their urine output is. So that's why they have this 0.5 milliliter per kilogram per hour as a guideline. When you start dropping below that, you need to worry and increase your monitoring. So when your patient is at risk for acute renal injury, which is probably almost every patient in the hospital, you really want to keep an eye on that urine output. You don't want to let it go for 12 hours, 24 hours. You're going to be missing signs and symptoms of renal failure. And the longer they're in these stages, the harder it is to get them out of renal failure. This is the stage where the BUN and the creatinine start to rise. This is where the patient was 5 hours ago. They had a creatinine of 1.9. Now they've got a creatinine of 2.5. Now they've got a creatinine of 3.4. It starts jumping and jumping hourly because the kidney is starting to shut down. They start to have fluid volume retention because the kidney can't handle the fact that it is getting an acute injury so quickly, starting to have electrolyte imbalances. We're starting to see the function shut down, which is what our signs and symptoms of renal failure are. Our first job is removing wastes. Our wastes are BUN and creatinine, so our first sign is BUN and creatinine going up. The second job is doing our blood pressure and doing fluid volume management, and that starts falling apart. Our blood pressure starts getting higher, our fluid volume retention starts going up, things start falling apart on the fluid volume blood pressure end. The acid-base balance end starts falling apart. Kidneys are supposed to be responding to your pH level and buffering things and getting rid of bicarb and keeping bicarb and excreting acids and excreting ions, and all of a sudden things are not working, so the acid-base balance goes upended. You end up with low calcium in this. Sorry, this is a mistake on this slide too. Let me fix this slide. I apologize. Fix your slides. This is hyperkalemia happens, but this should be hypocalcemia and hyperphosphatemia. So it's not really a wrong slide. It's just probably not as correct as it could be. Let me go back. So you're going to see your potassium they're going to start holding on to potassium. You're not decreasing, getting rid of things that you should be regulating. The acid-base electrolyte balance starts going off. They're not creating vitamin D. You're not absorbing calcium. You're holding on to phosphates. And remember, there's that seesaw there. So hyperphosphatemia, hypocalcemia. We start retaining fluid. And where does fluid start to accumulate? Fluid that's holding onto our bloodstream and making our blood pressure higher starts to leak in those loose capillaries, our hands, our feet, and our lungs. Fluid starts leaking in inappropriate places. So basically, when our kidney starts to break down, the signs and symptoms of jobs not being done are the signs and symptoms of our cues of worsening failure. Biggest cue, though, is the oliguria. Okay. The rest of them are the jobs falling apart. We will see the urine output drop. When you draw labs, you'll start to see electrolytes unbalancing, the BUN and creatinine rising, and things getting worse in terms of if we let this continue. Fluid retention will continue to the point because we're not stopping. This kidney is releasing aldosterone. It's retaining fluid, and that fluid can't be handled by the bloodstream, and it starts leaking out all over the place. So as this continues down the trend, you will see things worsening, and worsening is everything falling apart and all the jobs falling apart. So the first stages of this second stage is just a decreased urine output. Further and further and further, you start to see the jobs getting less and less done, and you will see things falling apart. So what we're looking at here is basically this happens in the next few days. Your patient will become acidotic metabolically. They will become hyperkalemic, hypocalcemic, hyperphosphatemic, and fluid overloaded. So we need to treat this, right? What are we going to do? Well, of course, we're going to monitor our intake and output. Hopefully it comes back to adequate. If it is dropping and getting worse, we're going to have to do some interventions. We're going to keep an eye on our lab work. Urine output, once it starts dropping off and you qualify as oliguric, they're probably going to start watching your BUN and creatinine levels. We're definitely going to monitor the fluid volume and level of consciousness, because as our acid-base imbalance and our fluid volume goes up, we could have problems with our tissues in our brain. So keep an eye on urine output. Once urine output falls off, we're going to be following via lab work and fluid volume. What are we going to do to intervene for this? All right. What are our problems here? Let's recap let's go in to think about what our jobs are and what our problems are. Our first job is remove wastes. It's not happening, so we're seeing an increased BUN and creatinine. So how do we remove wastes? Oops, I moved forward a slide. I shouldn't have been on this slide. Hang on, let me go back. Clear that one. I wanted to put this on the other slide. I didn't see that it moved forward. Yeah, that's the slide I wanted. Okay, so the first job is removing wastes. Our BUN and creatinine are going up, so we need to get rid of wastes. The best way that we can probably get rid of waste is to do dialysis. But we're not going to jump right into dialysis. We're going to try a few things first. We're going to monitor that BUN and creatinine to watch the situation. So now this is no longer a daily BUN and creatinine. They might be doing it every 8 to 12 hours or so. And what they're going to do is they're going to kind of leave that alone. There's not much we can do with managing waste. The only way we can take over that job by removing waste is to do dialysis. So the first one, we're going to put this here, remove wastes, which is BUN and creatinine. The only way we can treat that is dialysis. That's a pretty hefty intervention. So we're going to hold off. We're going to let those wastes kind of accumulate and hope that we can maybe treat the underlying problem in the meantime. The other jobs here is the other problem that we have is we are having an increased blood pressure and increased fluid retention because our renin-angiotensin blood pressure system is messed up. We can treat this one, retention. How do we treat this one? We're going to treat this one by giving diuretics to decrease the fluid. We can give blood pressure meds to drop our blood pressure. We can do a low sodium diet because that is all of what's happening with our blood pressure. We have increased blood pressure, increased sodium retention, and increased fluid retention. So those are the three things we can do to combat that job 2. We can go in there and intervene for that one. Job 3 is acid base. We can't really do anything about that. We're not good at regulating that. That will be dialysis. So we really can't touch that job. Our other job, let's see, what did we say? The other job was fluid balance. We're kind of taking care of that with the diuretics. So our fluid balance job with ADH in the brain. So the brain's down there screaming, I'm getting overloaded up here. Start peeing, start peeing. It stops sending antidiuretic hormone. It's like, just pee, get this fluid off of me. But the kidney's damaged, it can't respond. So we will help that with diuretics. We got to get that fluid off. The other job that the kidney has, so we've got 1, 2, 3, is vitamin D and calcium absorption. And we are ending up being hypocalcemic and hyperphosphatemic. So we can give calcium supplements, vitamin D supplements, because the vitamin D can't be converted on its own. We have to try and absorb it. So calcium, vitamin D, and we can do phosphate binders. because this system is out of control. We're not absorbing calcium. Our phosphates are getting high, so we can bind the phosphates, which will increase our calcium. We can give calcium and vitamin D. So we can take care of most of these jobs. The last job is red blood cells, which we can't really do anything about that one either. So we are kind of really stuck with very few interventions that are non-invasive, and those involve diuretics. Now, we said that diuretics can be toxic to the kidney. We need to manage those carefully. We can't just throw diuretics on the patient, because if we now give so many diuretics that they get dehydrated, we can cause more damage to an already damaging kidney. So we will use those diuretics carefully, monitoring our BUN and creatinine along the way. Low sodium, blood pressure medications, fluid restrictions to keep that fluid retention under control. If things are going out of control too quick, maybe that potassium is growing faster than we can keep up with it, they're getting super acidotic, we may need to go into something more invasive, which is dialysis. So we will try the diuretics to manage fluid retention, blood pressure, low sodium, and try to get that underlying cause under control in the second stage. Remember, our kidneys aren't really the main issue here. Our issue is that we have something else going on in our body that is causing kidney damage. So we have to get that under control. So we're going to basically still treat our pre-renal, intrarenal, or post-renal cause, whatever that is, and then hope that everything kind of comes back and the kidney starts to heal. In the meantime, though, we're managing symptoms, and we will do diuretics, blood pressure meds, low sodium diet, fluid restrictions, and we can, as electrolytes change, we could possibly add some of these things. It's basically symptom treatment. And if things get very, very, very bad and we have to get rid of wastes, or fix acid-base problems and we have to go on to dialysis, we will do so. But remember, least invasive to most invasive. If we are intrarenal problems with infection or nephrotoxic meds, get rid of those. Don't add any more if we can help it. Prevent any other symptoms, prevent prolonged episodes of hypotension, hypovolemia. If we're having an intrarenal problem, let's just say our patient's in acute kidney injury because they had a massive renal stone. They got blocked in the ureter, they're now in acute kidney injury, and now you let this patient get dehydrated for some reason. Now they've got double the damage to the kidney. They now have a pre-renal and a post-renal cause. The more things you pile on to risk the kidney, the more the kidney is going to have a hard time recover. So really our big things to manage this is symptom management and keeping the jobs of the kidney in mind will help you manage these symptoms. And really, so we're going to try and get the fluid off the patient and just watch the BUN, creatinine, and electrolytes and acid bases for worsening, because if it worsens, we're going to have to go to dialysis. Like I said, and a lot of this depends on whether you can get the cause under control. Let's say we have a car accident victim. Or a sepsis patient. They have a low blood pressure. They come to the ICU with a low blood pressure. We can't get that blood pressure up. We're trying. We're giving fluids to the car accident victim. They're bleeding. We're trying to replace blood. We're trying to fix the damage, the injury that's bleeding. They're going to the OR. They're spending hours with a low blood flow state. They will come out in second stage renal failure. And what we're doing is we're just trying to manage the patient the best we can. If we can't fix the underlying cause, they will go into renal failure. One of my favorite intensive care doctors will say, let the kidney go. We can always do dialysis. We'll get it back later. ABCs. Unfortunately, the kidney doesn't factor into ABCs at all. So we're talking best case scenario here. We gave them radio contrast dye for a procedure, maybe forgot to give fluids with it. They start showing signs of oliguria, and everybody realizes, oh my gosh, they had dye. We didn't give them any kind of flushing. Let's flush that dye out of there. And then we watch everything start to get better. We've been able to manage them with diuretics, fluids, blood pressure meds, low sodium diet, and we never get to dialysis. If on the renal, the car accident victim that spent hours in the OR with a low blood pressure, we may need to go to dialysis on that patient. The diuretics, the blood pressure, the low sodium, we didn't get that kidney recovered in time. We now maybe have to go to temporary dialysis to clear the waste and the acid-base problems that happen. So everything is on there's no 1, 2, 3, 4, 5, really. That 1 is a big 1. Diuretics, fluid restriction, temporary hemodialysis, not all 3. It goes in stages. And really, I think maybe I should write it out in terms of jobs that the kidney does, and least invasive to most invasive stuff. So temporary hemodialysis we really save for if the BUN and creatinine are sky high, the electrolytes are way out of whack, and they're super acidotic, then we will go to hemodialysis. The rest of it, we just let the kidney try to heal on its own by fixing the problems underneath, and managing their fluid overload. The biggest thing is preventing further damage to the kidneys. We know something happened. We know the kidney's oliguric. We know it's already stressed. We know it's already damaged. Please try to prevent further damage. Any patient that has a low blood pressure on top of a nephrotoxic med, you've got 2 strikes right there for kidney damage. The more strikes they have for kidney damage, the more at risk for long-term damage they have. So prevent further damage to the kidney. Monitor that fluid volume status by giving diuretics and giving blood pressure meds, just making sure that your diuretics don't dry you out too much, because hypovolemia is a risk factor for acute worsening. So a nice balance, monitor those labs really closely, but we're really managing our fluid volume status there. Renal diet, we will talk about the renal diet very frequently, much more common in the chronic renal failure patient. But renal diet is important. It means adequate calories. We don't want to overtax the body with waste products. The body already can't process waste products. So we don't want you doing too much digesting, we want to keep everybody resting. Adequate calories. The more calories you take, the more waste you make. So adequate calories, adequate protein. We're not saying don't eat protein, but this is not the time for you to be eating tons of meats and doing a high protein diet, because proteins make a lot of waste and the kidney is not functioning very well. Sodium restriction prevents edema, and if they cannot maintain an adequate diet, they might need enteral nutrition. Fluid restrictions, because if they're already fluid overloaded, we probably don't want them overloading themselves with fluid. We want to monitor their fluid. Again, we said flush, flush, flush. If it's an intrarenal cause, we will be giving fluid. If it's a hypovolemic or a prerenal cause, again, fluid restriction is going to be depending on your symptoms. So I know nobody wants to hear it depends, it depends, it depends. But it does depend on your patient. Your patient in stage 2 oliguric renal failure with no signs and symptoms of fluid overload, they will be able to drink. They won't be on a fluid restriction. Your patient in second stage oliguric phase that is 6 pounds up and swollen face, swollen feet, swollen hands will be on a fluid restriction. It really depends on your patient. And like I said, temporary dialysis is needed if we have high electrolyte imbalances, if we have acid-base imbalances or really high wastes that are causing mental status disturbances. But let your patient know that if they do go on dialysis, it is not guaranteed to be forever. This is temporary. This is an acute kidney injury, and we are treating it so that it gets better. Be sure to reassure your patient that just because they have an acute kidney injury does not mean they have acute kidney failure for the rest of their lives. We are hoping that in stage 2 we can treat them and they will go to stage 3 and stage 4, which is healing. Great. Wonderful. We have fixed it. And this is how we know we're watching that urine output, right? Because just because they went oliguric doesn't mean it's all lost. You're just in stage 2. As things start to heal, you fixed that car accident victim. Their blood pressure's been okay for a couple of days. You got that radio contrast dye out of there. And now all of a sudden you see urine output increasing. That means you're healing. That's amazing. The problem with the 3rd stage, though, there's one caveat before you can go and throw your celebration party. In the 3rd stage, the kidneys have recovered their ability to excrete waste, so their BUN and creatinine values start to drop, but they still haven't gotten that loop of Henle fixed up just yet. The glomerulus works, but the loop of Henle's not working, and it's not concentrating urine very well. It's almost fixed, but not all the way. So your BUN and creatinine start dropping, your acid base, your electrolytes, everything starts to get better, but you're peeing. You're in the diuretic phase. And so everybody throws up a big party, and they're like, yay, we're peeing, woo woo, let them pee, get rid of all that fluid, this is great. It is great, but you have to monitor your patient, because in this diuretic phase, they can become hypovolemic, which is then putting you back into pre-renal failure, and the kidney can fall apart again. So please, please, please watch your patient. You can celebrate quietly. And while they're putting out large amounts of urine a day, which is part of the diuretic phase, just make sure that they are adequately hydrating, getting fluid volume replacement, that they are not, they do need to get rid of fluid, but that doesn't mean they don't drink, they don't get IV fluids. They do need fluids because they are peeing out so much, they can't concentrate their urine. They can become hypovolemic very quickly and return into renal failure. So stage 3 is that cautious, yay, you're peeing, but we're not out of the woods just yet. We have to make sure that your input matches your output and that you are not getting dehydrated. And then stage 4 can last for the rest of the year. Your symptoms go away. You don't have high BUN and creatinine levels, but you do need to watch your kidney and treat it very carefully for the next year. It's healing. And it's recovering, and any insult, pre-renal, intrarenal, or post-renal can quickly send it back into renal failure again. So that is a very quick, and I'm going to break the slide here, and I'm going to do one side for acute renal, and I'm going to do another voiceover for chronic renal.